have unmuted. Let me know if you can't hear me online. My name is Sim. I'm one of the PGY3 Merge residents, and I'm very happy to present to you today on Delirium. I was thinking about it last night, maybe just because of how much I've been reading about Delirium, but we have a lot of codes in the department. We have code stroke, code STEMI, code AAAs gaining some traction. Thought about why we don't have a code Delirium. So I looked at, I don't have a printer, but I looked at some of the 6-month mortalities of patients who admitted to the hospital with our favorite emergencies. And then I thought I'd also plug Delirium in there. So bear with me, these are not great numbers, but sepsis. Oh, that better maybe, hopefully. Here's some mortality numbers for you guys. Sepsis, 20 to 50% at 6 months. Myocardial infarction, we love that one, 10 to 15%. Stroke, 15 to 30%. Pulmonary embolism, one of our favorites too, 8 to 15%. Heart failure, 10 to 20%. GI bleed, 5 to 10%. DKA, 5%. And delirium, 10 to 30%. So my biggest objective for this talk is to convince you today that delirium is a true medical emergency. For this talk today, we're going to talk a little bit about what delirium is and its different subtypes. We'll talk about why we're missing up to 2 out of 3 delirious patients in the emergency department, some challenges that presents. We're going to look at the evidence behind the best practices and guidelines and see if we can develop a framework to approach a delirious patient. Still nothing, eh? Still very quiet, eh? You guys can hear me okay in here? Hello? I'll keep talking, and you guys can let me know, and Naman can maybe handle the IT in the back. So we know delirium. Delirium is an acute change in cognition. It's flagged by fluctuating course, changes in perception. We know that we have patients who have high risk factors for delirium. So you can see from the chart, they've got high vulnerability, different predisposing factors. Evidence from ED studies show that our prevalence is about 7 to 24%, which is pretty high. And the number that I was talking about at 30.8% actually comes from a study by Kakuma and colleagues in 2000, where in 2 studies in 2 EDs in Montreal, they looked at patients who were discharged without delirium being recognized and found that at 6 months they had a mortality of 30.8% when it was compared to the mortality of delirious patient admitted to the hospital, which was 11.8%. So these are my 3 guinea pigs today, Tom, Dick, and Harry. They're triplets. Tom is on the left here. Tom is 85. He's got dementia, and he's coming in with hypoactive delirium. This is the kind of delirium that's usually associated more with weakness, lethargy, and decreased psychomotor activity. It's the most common, and it's the one that we miss the most in the emergency department. Dick has the middle child syndrome. He comes in with agitated delirium. He is loud, he's agitated, has perceptual visual hallucinations. This we're better at picking up at a prevalence about 2 to 20%. And lastly, the youngest one, Harry, has mixed delirium, so he's got a combination of both, which depending on the literature, anywhere from about 43 to 55%. However, as I said, in the emergency department, we're missing about 2 out of 3 deliriums. That results come from this study by Bellavance in 2000, where they took 447 patients from the emergency department. They had psychiatrists diagnose them with delirium from the DSM guidelines. And they had emergency physicians who used the ED chart review as well as a mental status checklist and found that both combined yielded only about 35% recognition of delirium. Not only that, but patients who were diagnosed with delirium, only 9 out of 16 actually had the term delirium documented on their chart. The findings were replicated in another study, this time in 2009 by Eli and colleagues, who used a CAM score, which we'll talk about, and found that, again, the agreement was about 24%. So as emerged docs, we were recognizing 24%. And this time, they also found that out of 16 patients, only one whose diagnosis that, sorry, I'll start that over. 1 out of 16 patients who were delirious were recognized by hospitalists when we missed them. So what that essentially boils down to is the fact that if we miss delirium, it often goes missed by our hospitalist colleagues as well. They found that hearing impairment, dementia, and CATs less than 4, so functional dependence, had statistically significant relationships to risk factors. And if you had the 3, so the jackpot, you've got about a 46.2% chance of delirium. These findings are a bit interesting because they are asynchronous with another study that was done out of the United States where they asked emergency physicians about their comfort level with delirium. As you can see on the left side, they found that 97% of emerged docs found that their knowledge levels for the diagnosis and assessment of delirium was at intermediate, advanced, or expert level. On the right side, 41% of doctors, emerged docs, said that they were neutral, not concerned, or less concerned about discharging patients with delirium, which we know has a high mortality. So this tells us that delirium has a high prevalence in the emergency department, high mortality, high morbidity. We're missing quite a few delirious patients, and even the ones that we are recognizing, we're not quite documenting. And as momentum setters in the hospital, if we're missing delirium, it often goes missed by hospitalists as well. And so there's significant asynchrony in that data, which can lead to misdiagnosis, delay in diagnosis, inappropriate investigations and management, and most importantly for us, unsafe discharge for our patients. And so today, I'm hoping that we can talk a little bit about why that is and see if there's anything that we can do about that. The same study that we mentioned previously asked doctors what are their biggest knowledge gaps or challenges with recognizing delirium and the ED. And those findings were less surprising. They said that the ED environment, our home, delirium in patients with dementia and getting collateral information, and time restraints were the 3 most common reasons or challenges with recognizing delirium. We'll talk about the first one. This is a quote from one of the physicians. He or she says, the biggest challenge is the department. You've got limited time, limited resources. You've got a static snapshot of a dynamic disease. And the issue right now is patient flow and numbers. We all work in the emergency department, and we know that that's true. Dr. Brittany Ellis agrees with that as well. Some of you might remember Dr. Brittany Ellis. She's a graduate of the program and currently works in the city of Bridges, Saskatoon, as an emergency medicine physician in the geriatric lead. She says that patient block and patient movement is a big concern. And her hypothesis is if we can increase the flow in the department, that allows our emergency physicians more time to assess and diagnose and prevent delirium. And her findings her hypothesis is pretty well supported by the single center retrospective chart review by Timmy and colleagues, where they analyzed patients who were admitted to the hospital, and then they looked back at their stay in the emergency department, and the results were somewhat surprising. Keep in mind that they didn't include patients with dementia or stroke, but even without the population, they found that patients who developed delirium had about a 50% greater time in the hallway at about 12 hours. They had 5 ED transfers within the rooms, and they had, understandably, a longer hospital So we know that our emergency department, unfortunately, is not the best place for our delirious patients, and if anything, can predispose them to delirium. The other thing that came up in those challenges is identifying delirium in patients with dementia. This physician says, we've all had that patient, and I think we all have, from the nursing home who's older, doesn't communicate, and comes in with altered mental status. No baseline, just altered. And so the real challenge is figuring out what has changed today. We've all had patients in the emergency department, and I love when a nursing home patient comes in with this pack of 30 pages talking about all the medications they've ever been on and the influenza vaccine they had in 1967, but no mention at all of what they look like on a normal Wednesday. So, is that patient with dementia just their baseline? Do they have delirium? Or do they have both, which is delirium superimposed dementia? We know that there's differences in how these entities present. We know delirium is more acute, it's more fluctuating, and dementia is insidious and it's constant. But as dementia becomes more severe, the lines blur. There's even a hypothesis that the incidence of delirium might exaggerate the trajectory of dementia, which is concerning for us because 26 to 40% of emergency department patients present with cognitive impairment, and so it's very important for us to recognize the difference. And that's where getting a baseline becomes crucial. Is this patient changed from their baseline? There's not a lot of studies on delirium superimposed dementia. This is one of the few prospective studies that they found. There's almost no evidence in the emergency department. The study by Donna Fick and her colleagues found that patients with dementia who had delirium superimposed had a 25% short-term mortality, which we've seen before. They had almost double length of stay in the hospital, and they found that delirium in these patients existed at about 32%. Risk factors include male and, understandably, severity of dementia. It's also interesting when we look at the left about how many of those clinical covariates are potentially modifiable and preventable. A lot of these patients presented with dehydration, falls, and sensory impairment, which I think can be addressed in ambulatory settings as well. We often call the nursing homes to get a sense of what their baseline is. So it's a pretty neat study by Donna Fick and her colleagues where they interviewed nursing home health staff and asked about what helps them differentiate delirium from dementia. And the three themes that showed up included negative emotions, acute change, and familiarity with the patient. When I talked to Courtney Munch, who's an advanced practice nurse at DOH and in the Department of Geriatrics, she says if you're considering discharging a patient with dementia who you're concerned about delirium, definitely recommend a formal geriatrics consult. And if you don't know, then it's better to err on the side of caution, which is something that the NICE guidelines from the UK agree with as well, where they say if there's difficulty distinguishing, manage the delirium first. The third challenge that was brought up in the previous study was screening for delirium in the emergency department. This physician, again, I think echoes some of our feelings about us being comfortable with the obvious delirium, but being petrified about patients that were missing it in. They're wondering if there's any tests that is pretty good for delirium, for screening for delirium. Almost like they knew how I wanted to talk about my slides. Dr. Deb Eagles, who some of you might know in the department, wrote in a paper in 2010 for the Canadian Journal of Emergency Medicine recommending cognitive screening for older ED patients and advocated that it's almost standard of care. And she's not the only one. Cognitive screening for older patients in the emergency department is recognized and recommended by multiple international geriatrics and emergency medicine agencies. The problem, though, with cognitive screening is ones that you would think about. There's many different tests, as you can see on the bottom. They take anywhere from 2 minutes to 30 minutes. have various levels of sensitivities and specificities, and are thus not very suitable for the emergency department. Fortunately, we have something that's quick with decent evidence and validated in the emergency department, and that is the delirium triage screen and the brief confusion assessment method. Takes about 30, the triage takes about 30 seconds, but the entire process takes about 2 minutes and is validated in the emergency department. The first step is a highly sensitive screen that asks 2 questions. 1, does the patient have altered level of consciousness defined by a RASS score of anything other than 0? And 2, if they have any attention. So in the study, they asked patients to spell the word lunch backwards. And if they had more than 1 error, they're positive. And so you could move on to screening them with the brief confusion assessment method. They found that this test had a 98% sensitivity, which is exactly what we needed to rule out patients. If a patient is DTS positive, they recommend the brief confusion assessment method. This has 4 features, where you need features 1 and 2 and any of 3 and 4. Feature 1, altered mental status or fluctuating course that you can determine based on the patient or collateral information, which is crucial. Feature 2 is inattention. So they asked the patients in the study to tell the months back from December to July, so 6 months. So you needed both of those to be true. And then 1 either of altered level of consciousness, so a RASS that's other than 0, or this evidence of disorganized thinking, which they defined as 4 questions and 1 command. Those questions are simple. Does a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2? And can you use a hammer to pound a nail? And for the commands, they talked about hold up 2 fingers. And so you hold up 2, and then you ask them without showing it to them to do the same. And the study they found, when used by ED physicians, was 84% sensitive and 94% specific. And not only that, they also found that a trained researcher, so a non-ED physician, had pretty similar sensitivities and specificities, which begs the questions if there's other people other than an ED physician, so nurses, who can employ this as well to improve our diagnostic accuracy. CAM, or the confusion assessment method, is actually no strange thing at the Ottawa Hospital. There is a corporate standard operating procedure for admitted patients for the nurses to complete the CAM score for patients that they're concerned about delirium. Again, talking to Courtney Munch, doesn't really happen, and I think we know why. There's time constraints, there's language barriers, and there's limited training, which is what they found in another study, or in 2 studies, where they assessed the use of the CAM score by nurses, and they found that nurses were pretty good at telling us who doesn't have delirium, but the assessment rate for delirium with the CAM score is about...
And hash browns and bacon and fruit.
I'm just going to ask whoever that is to mute themselves. Thank you.
Nice.
Yeah. So
He was too drunk.
I think that's Matthew, if you wouldn't mind muting yourself, my friend. No worries. So yeah, nurses are not, they're great at excluding delirium, but not quite at recognizing it. Which brings about 2 points. One is that if there's a need for more training for nurses, it takes a brave person to recommend that, and unfortunately, I'm not that brave. Or 2 is that it perhaps means that as ED physicians, it's our responsibility to employ the CAM score. So just to summarize, our ED environment is awful for delirious patients, which tend to, it's almost a risk factor that it has associated increased length of stay and increased incidence of delirium. Delirium and dementia are common, and it's important to establish a baseline to assess the difference between both. This is a high-risk population who you should be considering a formal geriatrics emergency medicine consult if you're considering discharge, and to utilize the DTS and BCAM score to improve our diagnostic ability to diagnose delirium, especially in high-risk patients, so patients who have a history of dementia older age, or sensory or functional dependence. Let's try to put that together into a bit of a framework that we can use for our next patient that we see in the emergency department that we're concerned about for delirium. The ADEPT tool was created by a consensus of emergency physicians, nurses, psychiatrists to provide a bit of a framework for the undifferentiated patient with confusion and agitation in the emergency department. I'm also going to talk a little bit about the NICE guidelines that are developed out of the United Kingdom, which is more for admitted patients with delirium, but hopefully we can put them together to make a bit of a framework. Step 1, assess. On the right side here is a JAMA study that looked at 315 studies looking at 101,000 patients with delirium. Only about 7 of those studies, unfortunately, were in the emergency department. And I've highlighted the 4 or 5 common precipitating factors that are associated with delirium. So you can see neurological injury, anemia, infection, metabolic abnormalities, and medications, which is just a reminder that although we talk about the DIMES mnemonic, that the DIMES only recognizes about 5 or so entities, and there's up to 112 that can predispose patients to delirium. So it's important that we rule out life-threatening conditions in these patients, make sure they don't have a myocardial infarction, hypoxia, severe sepsis. We do a detailed history and physical, including a medication review, because we can see from the bottom how medications like benzodiazepine, opioids, sedatives do have a risk of precipitating delirium. And lastly, rule out the more common things, which we do with our blood work. Step 2, diagnose. This is where establishing that baseline mental status becomes important. Again, from the same JAMA study, they looked at 33 predisposing factors associated with delirium, and they found that advanced age, dementia or cognitive impairment, and functional impairment were the 3 highest risk factors for developing delirium. So in these patients who have certain risk factors, remember to establish a baseline mental status, employ the DTS and CAM score, and differentiate delirium from dementia or other psychiatric conditions. We then move on to blood work. Not a lot of evidence on what should be ordered, but we all have a general idea, basic blood work, some imaging, ECGs. This is an interesting study, which is a survey on current practices that actually has Dr. Krish Yadav, who's involved as well, where they sent surveys to emergency physicians and asked them about what lab work that they ordered, and some interesting findings here. On the left, we've got the JAMA study with the common precipitating factors, and we can see on the right a bit of a heat map. And remember, this is the tests that are ordered by ED physicians for non-septic or afebrile patients. CBC, urea creatinine, and electrolytes seem to be common. Extended electrolytes, perhaps not as much, which I thought was surprising considering electrolyte abnormalities do make up for a considerable portion of delirious patients. Urinalysis and CT heads is something that we'll talk about. Abdominal x-rays are no longer in fashion. Urine dipstick, I wasn't sure it still existed. And blood cultures I thought was interesting. We know that we're having a bit of a shortage with blood cultures as well. And so I did a little bit of digging into how many patients who are afebrile without any signs of infection have positive blood cultures, and it's not a lot. A JAMA study in 82 found that afebrile bacteremia is more common in older patients, which doesn't help us, but also patients who have indwelling catheters, as well as a history of malignancy or immunodeficiency. So those are some factors that will help you decide on if you need to get blood cultures for a next delirious patient who's not febrile. What about urine? We all know the old age association of UTIs with delirium, but a recent systematic literature review has actually failed to demonstrate a link. They found that the evidence was mostly of poor quality. So they found that UTIs were diagnosed in different ways. Some studies were diagnosing it as a urine dipstick, urine analysis, and only a few waiting for urine cultures. And they also found delirium was diagnosed in different ways. So is it confusion or things like that? But not all studies had documented delirium. And so their recommendation states that there's no high quality evidence to suggest that UTIs have a link with delirium. Asymptomatic bacteriuria, as we know, has a high prevalence in this population and poses a threat for us to misdiagnose and mistreat these patients as UTIs. The current Loeb criteria for urinalysis recommends that we only get urinalysis in patients with acute dysuria or with fever and urinary symptoms, and for patients with an indwelling Foley to look for new onset delirium, rigors, new CVA tenderness, or fever. What about CT heads? There seems to have been a change in practice, especially after 2000. The systematic review by Emily McDonald and colleagues found that 13% of patients with acute confusion had positive CT findings, and that functional focal neurological deficit, was the most common reason why. There's not a lot of studies in the emergency department, but yet another study from the land of the living sky, from Dr. Brittany Ellis and her team, where they looked at the utility of head CTs on patients in the ED, which is the first of its kind. They looked at patients who were older than 65, who had evidence on their chart for delirium, but no objective diagnosis. So that included confusion, the terms confusion, delirium, altered mental status, hence the title of the study being suspected delirium. And they found that 4.66% patients of age greater than 60 and symptoms of potential delirium had acute CT findings. Choosing Wisely Canada, therefore, currently recommends that a CT head be ordered for delirious patients only if there's focal neurological deficit, history of trauma or falls, GCS less than 14, and signs of increased intracranial pressure. Going back to that study, Dr. Yadav's study, Canadian ED physicians are pretty much in line with those recommendations. Surprisingly, the least amount of evidence that I found for ED management was in prevention in the emergency department. The prevention employs the 4M frameworks of age-friendly healthcare systems: mentation, mobility, what matters, and medication. For mentation, we ask about screening for cognition, screening for delirium, which we've talked about. Mobility, assessing falls and risk for falls and encouraging safe mobility. What matters talks about engaging families and also respecting patient values, whether that's end of life, advanced care directives, with a real focus on involving family with their care. And lastly, medications, to reminder to reorder home medications for your patients or your geriatric patients who present to the emergency department, especially if there are some medications that they're on for agitation or pain. Treatment for delirium is no surprise. It's about treating the cause, but there's so much more than that we can treat as well in the emergency department. There might not be a lot that we do for these patients in the ED, but anything goes a long way. It's the simple and the basic things. It's reorientation, oral fluid replacement, or IV fluid replacement. We saw a high proportion of patients with delirium had dehydration. Early mobilization, vision and hearing aids, again, a risk factor for developing delirium, and the basics: sleep, pain, and reordering their home medications. What about agitation? We've all had the old geriatric patient who is screaming in the halls of OBS. And so I'm hoping in the next couple of slides that we talk about a bit of an approach. Verbal de-escalation has been shown to have pretty good response to agitated patients in delirium. There's an excellent consensus that was generated by the American Society of Psychiatrists. That's in the top left side for a QR code, but they essentially talk about respecting personal space, so keeping 2 arm lengths away from your patient, not being provocative, being concise, identifying what the patient wants and why they're agitated. Is it pain? Is it confusion? Is it dehydration? Is it constipation? Laying down the laws, offering choices, and debriefing the patients and the staff. What about restraint? I've always found the concept of restraints to be interesting because in certain ways we do take away from the patient's autonomy. So a study in the ICU in China, so not really in the emergency department, but found that 40% of the patients who were restrained developed delirium. They found that risk of delirium with 2 uses of soft restraints increased the risk of delirium by 2.38 times, and 3 times use of restrictions to be 3.62 times. Dr. Miriam Tak, who is a geriatrician at the Ottawa Hospital, who's moved from the United Kingdom, tells me that she is shocked at our use of soft restraints. She says in the United Kingdom, she had never seen geriatric patients be put on restraints and that it would be considered elder abuse. In her study, not her study, so in her findings, she found that 1,700 orders for soft restraints were ordered in the at TOH at the Civic and General Campus in the last year alone. And so she recommends the least restraint last resort principle, which again, is at the link at the bottom, to really think twice about using physical restraints in patients with delirium, keeping in mind that they do have an increased risk of further worsening their delirium, and again, thinking twice about taking someone's rights away. What about our favorite things? Drugs. Benzodiazepines are contraindicated in the treatment of agitation for delirious patients, unless the delirium is from alcohol withdrawal. A study on the left here found it's a retrospective cohort study with patients over 65 years old, unfortunately excluding patients with dementia again, who looked at patients who were admitted to the hospital and the drugs that they received in the 24 hours preceding, so including their ED hospitalization. And they found that benzodiazepines by themselves, as well as in association with opioids, statistically significantly increased the risk of developing delirium. Pain and not opioids was also associated with a risk of delirium. These findings were replicated in another study where they found that patients who received over 5 milligram equivalents of diazepam had an increased risk of developing delirium with an adjusted odds ratio of 3.5. What about antipsychotics? Antipsychotics have had a difficult history in the emergency department and in the literature. Back in the 90s and 80s, there were FDA warnings developed with Haldol about the risk of sudden cardiac death. And all the studies that you see on the left actually show no benefit to Haldol use. However, recently, literature, mostly in the ICU on the right side, shows that there may be some benefit in managing delirious patients. A Cochrane study did a far more in-depth analysis than I just did in the last slide, and they found that there's no data currently to support the use of antipsychotics. It doesn't change the duration of delirium, doesn't change length of stay in the hospital. They also found that most of these studies were low quality and that EPS symptoms were no different between antipsychotics and non-antipsychotics, and also between typical and atypical antipsychotics. Just the last part. So reviewing NICE guidelines, they do recommend a cautious use of Haldol if needed for very short term in patients with agitation who you have no other alternatives. There's an excellent article written by Dr. Kiran Rabaru, who is a psychiatric geriatrician at the TOH, who looks at the evidence at multiple different agents and recommends different doses. And there's a table for you there for some commonly used agents that you can use for your delirious patient. We've talked a lot about data today, a lot of evidence, but I just wanted to highlight that a lot of the evidence is of low quality. Not a lot of retrospective chart reviews, but a lot of case studies and such. And so evidence and data should not dictate your management, but rather guide it. We've also talked a lot about different people. We've talked about nurses, home care workers, physicians. We've talked about numbers. But the one thing that I haven't talked about is the patient. There's a very interesting study, it was one of few, that actually interviewed patients with delirium and asked them about their experiences. I wrote down a few things last night. Again, I don't have a printer, so I did this on hand, so bear with me. These are some of the things that patients with delirium have told interviewers. That day, everything hurt so much. I remember I started yelling. I was seeing various weird things. I thought someone was trying to poison me. I remember I was so awfully thirsty. I didn't care if I suffocated or I vomited. Nobody would give me water, and I know I wanted to get out of bed. I remember being angry because I couldn't sleep. What's also interesting is that patients who exhibit behaviors like this often don't forget. There's studies that patients wake up the next day or regain their consciousness and actively remember the things that they had said and done to nurses and healthcare workers. They talk about family members seeing their loved ones trying to punch physicians and punch healthcare workers. And so while we talk about symptomology as in hallucinations and visual perceptions, these are real patients who, as you can see things, they hear things, they don't have control, they're in a foreign environment, they're being moved 5 times in the emergency department, they have a high risk of dying. Not only for the patients, but for the family members who have to see their loved ones in a way that they've never seen before. For nurses who have to physically restrain these patients and endure a lot of physical and emotional feelings towards this. And I think that is the reason why delirium is a medical emergency. Yeah, there's numbers and high mortality, but it's really the human suffering behind it that I think is a reason why it needs to be respected as a medical emergency. So the next time you see a patient you're concerned about delirium, assess them. Make sure they don't have any life-threatening disease. Take a detailed history and physical. Diagnose them after establishing baseline mental status, which I think should be a standard of care. Use the DTS and BCAM score to further validate your diagnosis and identify risk factors like old age, dementia, and functional dependence. Evaluate them based on blood work, based on history and physical. Consider urine analysis only if indicated, as well as a CT head if it meets criteria. Do as much as you can in the emergency department to engage patients' families. Thank them for being there. Reorder their home meds. Orient them to time and place. Treat the pain. Treat the hydration. Console them. Comfort them. And if they're agitated, try verbal de-escalation before you reach for soft restraints or antipsychotics. And with that, I'll open up to questions. And just before I end, I just want to thank Dr. Deb Eagles for supervising